This is Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Dushyant Sahani, recently from the Department of Radiology at the Massachusetts General Hospital, and currently professor and chair of the Department of Radiology at the University of Washington Medical Center, who is the corresponding author of one of our featured papers in the current May 2019 issue of RadioGraphics. The paper is entitled Abbreviated MR Protocols for the Abdomen. Dr. Sahani, welcome to our podcast.
Thank you, Jeff. I'm delighted to be speaking to you. And at the outset, I must say this was a collaborative effort that culminated into a very fantastic review article.
Terrific. Well, thanks so much for joining us today. Dushyant, your paper addresses the use of more efficient abbreviated abdominal MR protocols to reduce scan time and interpretation times, thereby improving the patient experience and optimizing machine and room, technologist and radiologist resource utilization. Much of this is the result of relatively recent advances in MR acquisition techniques. Can you briefly review some of these techniques, such as parallel imaging, compressed sensing techniques, and the 3D or volumetric T2-weighted pulse sequences that you feature in your paper?
Yes, Jeff. MRI is one of these amazing modalities that have transformed how we care for our patients, but it's also a high-value resource, and it creates a bottleneck both with patient access, but also with patient compliance. So certainly the new advances in MRI and also the knowledge about the disease process and what value sequences add to is changing how we practice MRI. So one of the big challenges with MR has been the long acquisition time, which stems from segmented sampling of case space, and combined with the demand for physiologic measurements that require higher spatial and/or spectral resolutions. Now, therefore, there have been attempts made by investing in technologies to accelerate MRI acquisition. And this is due to not only improvement in understanding of the physics, but also better software, better hardware, and the computational power. So one such example is compressed sensing. It is a method for accelerating MRI acquisition by acquiring less data through undersampling of case space. So you undersample and you process that information, assuming how rest of the data would look like. Whereas parallel imaging is a technique that can accelerate the acquisition by allowing image recovery from the undersampled case space. The process is accomplished through phase-data coils, which contain multiple independent receiver channels. So you are acquiring from multiple sources, so that's why shortening the time. Now, similarly, with these better acquisitions and also post-processing with almost near isotropic data, we can now get a 3D T2-weighted acquisition and process the 3D data sets to create 2D images in desired plane. So combination of all these methods and also generating image quality, which meets the demands to give a confident diagnosis, both for radiologists as well as the referring physician who look at these images and make their decision, has led to adoption of some of these sequences in the clinical realm.
Terrific. Thanks for that. Now, after a brief review of the positive economic benefits of some of these abbreviated MR protocols, the paper delves into specific clinical applications, beginning with the liver. Let's begin by discussing the screening and surveillance of hepatocellular carcinoma. Can you detail the protocol that's described in the paper by Marks and Besa and Lee that you reference? And then we'll review Figure 1 just to illustrate this concept.
HCC screening has become a major endeavor because it's a healthcare crisis we have from chronic liver disease and the ramifications that it lends itself to both the patient morbidity, mortality, as well as healthcare costs. And as we know, screening based on imaging as well as some blood markers is well accepted and adopted worldwide. In US especially, and also in certain parts of Europe, MRI is one of the most widely used imaging techniques. Now, given the higher demand for HCC screening, for example, in our body MR practice, HCC screening can be anywhere from 20 to 25% of the volume. So what some of the investigators have looked at is they looked at a detailed protocol that was created by using hepatobiliary MRI contrast agent, gadocetate, which has both a dynamic phase as well as a hepatobiliary phase. And they looked at only few sequences, one being mainly relying on the hepatobiliary phase, the underlying premise being that a benign hepatic nodule, which are solid, will show uptake of gadocetate at 20 minutes, whereas malignant nodule in general will not show, either will show reduced uptake or no uptake of the contrast agent. And you use some sequence like a T2-weighted sequence to define if the lesion which are not showing uptake are, or those who are hypodense, either if they are cyst or other benign lesion or they are solid lesion. The premise being if the lesion shows no uptake and if it's not bright like a cyst, we will assume those are at-risk lesion or a malignant HCCs. So these three investigators, they took a complete protocol, which is, as we know, multiple sequences, and they selected a T2 sequence and a 20 minutes delayed hepatobiliary phase sequence. And they made some investigators, readers, evaluate these sequences, and they compared to a standard protocol and how their performance was. And it turns out by using these limited sequences, basically just two sequences, they formed they've identified a comparable performance as you would have with a dedicated protocol. And the radiologist's confidence was also very high. So in essence, some of these sequences that we use in our conventional protocol might not be needed. We can be very creative in terms of what sequences add value to our practice. Moreover, radiologist time can also be shortened by just looking at that. So these numbers are really impressive, and as we understand, this is a retrospective analysis, so a lot of prospective work is being done, so I will just caution the reviewers that this is still, we need more data. Yes, so Jeff, figure one is from a 44-year-old gentleman who has a known diagnosis of cirrhosis. And we are showing three images. The image A is an axial contrast enhanced T1 weighted image obtained after a hepatobiliary contrast agent, gadocetate. This was obtained at 20 minutes, and which shows a low density lesion. That means liver is bright, but this lesion, about 2.7 centimeter lesion, is dark. Then we look at image B, which is NC, which is an axial diffusion weighted MR image, and in apparent ADC map, which is apparent diffusion quotient map, and shows that lesion, which is greater than 2 centimeter, actually shows diffusion restriction. So by both measure being not showing uptake of hepatobiliary contrast agent in a cirrhotic background, but also a diffusion restriction confirms the diagnosis of a malignant lesion. So this image exemplifies the value, how we can apply this abbreviated protocol with just limiting to 1 or 2 or maybe 3 sequences and still gain the diagnostic benefits that we desire in this type of patient population.
Terrific. Thanks, Dushyant. So next, the paper proceeds to review the use of MR in the detection of liver metastases and in fatty liver disease surveillance. Any comments on these applications as we show our viewers Table 1, which summarizes these specific protocols?
Jeff, the application of MR, as we have seen as a common theme, is expanding, and we are becoming victim of our own success. We are showing tremendous value. The adoption is increasing, in the clinical realm. So in liver is a prime example that we started using liver with MRI, and we gradually aspired to give a very comprehensive imaging. That means not only to detect and characterize, but also stratify risk for patients. Now, that approach might not be prudent given that the needs of our colleagues could be very task-specific. Let's take, for example, in a chronic liver disease setting where we want to quantify presence of fat or fibrosis or even iron. Now here, these patients are being monitored to look at either progress or response to kind of various interventions, including medical management. Now, in these settings, the first protocol can potentially be comprehensive, but the follow-up protocols can be abbreviated to include few sequences. And that is mainly to quantify changes in the liver to assess either progression or response to treatment. Similarly, in patients with liver metastases who might or might not be a candidate for liver resection. So those who are being considered for liver resection, I would say we should still do a more comprehensive protocol. But a lot of these patients who are on a clinical trials for looking at response to therapies, these patients, we are looking at overall tumor burden and, how it changes doesn't have to be very subtle to make a decision. So here in these cases, what investigators have done is they applied the similar approach. They took a dedicated protocol and looked at very specific sequences, either using a gadolinium hepatobiliary contrast agent or looking at a dynamic sequences and see can we eliminate various other sequences and rely on a few specific sequences based on their contribution to the diagnosis. And they looked at that actually with using either two or more readers when they evaluated limited sequences, the performance was pretty desirable and meets the expectations for a diagnostic test, but also meets the expectations from our clinical colleagues without compromising patients' management in a negative way. So as I show you the next protocol, and this is on the top of table 1, we'll review a standard MRI protocol for HCC screening. And as you can see, there are multiple sequences. I won't list all the sequences, but to summarize, we do a chronal sequence just to get a lay of land, to define our other sequences. Then we have a FSCT2-weighted sequence. This is basically to detect and characterize lesion. We have a fusion-weighted sequence, which is generally used for characterization, but now increasingly also being used for detection. Then we have a chemical shift imaging with in and out of phase sequence, and the dynamic sequence is so critical because that forms a foundation for some of the diagnostic criteria for HCC diagnosis. Then we have delayed sequences, and also if one is using a hepatobiliary contrast agent, then a sequence at 10 and 20 minutes. And as one can imagine, this is a lot for a patient to handle, but also it takes more than 30 minutes MR slots. In many times, it's over 40 minutes, 60 minutes. So the abbreviated protocol, which is listed below that for HCC screening, and these protocols are based on the publications, and of course the protocols will evolve based on individual practices. So one abbreviated protocol which is listed is you use only single shot FSCT2 weighted images in axial plane and a delayed hepatobiliary phase images at 20 minutes. These are T1 weighted axial images, and you look at lesions at T1 and then compare them to T2 weighted sequence for if they are bright or not. Similarly, the protocol, which is from another site, uses instead of single shot sequence, they are using diffusion weighted sequence axial, and a similar 20-minute sequence with T1 fat saturated sequence. Another protocol which is not using a hepatobiliary phase contrast agent but use a conventional extracellular agent. There they rely on axial non-contrast T1 weighted fat saturated sequence, before contrast, and a dynamic sequence, which is a breath hold sequence in arterial, portal venous, and delayed phase. And again, these are, I must emphasize, breath hold sequences, so overall time cuts down. When we look at sequences for non-alcoholic fatty liver disease surveillance, it is again a axial and coronal single-shot T2-weighted sequence, a 3D spoil gradient echo sequence, and a 2D gradient echo MR elastography. And then we move to abbreviated MRI protocol for metastasis to the liver, and we have an axial T2-weighted with fat saturation, axial diffusion-weighted sequence, axial in and out of phase T1-weighted sequence, and these three sequences, which are basically a less than 10 minutes protocol, can give all the information for metastasis workup. The abbreviated protocol, which we are exploring in our own practice, and we have published our results for colorectal cancer metastasis to liver, constitutes a coronal single-shot FSCT2-weighted images, and axial diffusion-weighted images, and a delayed sequence of T1-weighted fat-saturated sequence after hepatobiliary contrast agent that is acquired at 20 minutes. Now, the third thing comes is, how do you make this happen? If something takes 20 minutes to acquire, that defeats the purpose of a shorter protocol. The way you do it is you give the contrast agent when patient is in the waiting area, and you take them for scanning on the table more than 10 minutes later. So by the time you set up, you are close to 20 minutes, and you acquire the T2-weighted sequences, which are not as affected by the hepatobiliary phase. The diffusion is not as much influenced, and get all the three sequences in less than 10 minutes protocol.
Terrific, thanks. So, Dushyant, the next section details some abbreviated protocols for the evaluation of cystic pancreatic lesions, and this is summarized in Table 2. And the use of T1-weighted in and out of phase imaging for adrenal incidentalomas that don't meet the unenhanced CT criteria for benign lesions. You then review the surveillance of small renal masses, defined as those that are less than 4 centimeters in diameter. Can you describe the protocol that's used in this situation? And we'll take a look at Figure 5, which illustrates this concept.
Jeff, as we have discussed earlier, the theme is similar. As we have a better appreciation of problems, whether the knowledge of the genetics or risk for patient, or incidental detection of lesions through other imaging modalities, the utilization of MR is growing. And, incidental adrenal lesion or renal lesion is a prime example of that. And what we learned that for adrenal lesion, for example, the dynamic images have less value on MRI as we have on CT. On CT, we are often looking at washout characteristics of a lesion to characterize them as benign or potentially malignant. Whereas on MRI, we are looking at presence of intracellular fat, and looking at in and out phase sequences, but also a T2-weighted sequence and diffusion-weighted sequence to assess if these are too bright or they show diffusion restriction, so we can make a potential assessment of the risk of the lesion. So these three sequences don't take as much time. Similarly, on the kidney side, the dynamic images, although they are valuable, but now when we look at a high-quality diffusion-weighted sequences, some of the in and out of phase sequence, we can characterize a solid lesion, whether it is a fat-containing a lipid-poor or an intracellular fat-containing lipid-poor angiomyolipoma, or these are potential renal cell carcinoma based on the combination of these sequences. And therefore, the abbreviated protocols are basically using in and out of phase axial images, or coronal if you prefer, a single shot FSCT2-weighted images, and the diffusion-weighted images. And these three sequences, most studies are showing, serve the purpose, and you can characterize most of the lesions. So let's look at Figure 5 as an example of how you can use this protocol. Now, this figure, as I'm showing you, is from a 68-year-old gentleman who was undergoing an active surveillance for a left renal mass found on a chest CT. And we can see there are three images. We have a coronal single-shot FSCT2-weighted MR image, an axial diffusion-weighted MR image, which is image B, and an axial apparent diffusion coefficient map, which is C. So what we see is a 2.3 centimeter exophytic lesion in the upper pole of left kidney. The arrow points to the lesion. And these are, of course, concerning for either a renal malignancy or lipid-poor angiomyolipomas, and that determination can be challenging on CT. Now, on coronal in-phase and out-of-phase images, what is obvious is there is no fat component in the lesion, and the lesion has remained stable from initial CT examination. So we have to, given patient's age and other risk factors, we will have to assume this is a benign lesion, and we will continue to surveil them, and this further surveillance can be with CT or ultrasound, because what we are looking at is change in size and not so much change in character.
Right. Terrific. So, Dushyant, now obviously multi-parametric MRI for the evaluation of possible prostate cancer has become mainstream over the last few years. Your paper discusses the use of abbreviated MR protocols in the targeting of potential biopsy sites rather than its use for proven prostate cancer staging purposes. Can you discuss the use of biparametric MR protocols in this setting? And we'll put up table 3 as you speak about the protocol. And then let's review figure 6, which I think nicely demonstrates this concept.
Jeff, on the prostate, multi-parametric MRI has made a tremendous contribution for accepting MRI as a modality of choice to evaluate patients suspected of having prostate cancer. Moreover, the guidelines and also the diagnostic criteria and how we interpret these images have evolved using these multi-parametric criteria. So that is a standard of care for staging purposes. But for patients where we need to help in guiding biopsy, we don't have to do all those type of sophisticated dedicated MRI. We can certainly modify based on the need, especially for sampling purposes. We can use only limited sequences, mainly the T2-weighted and diffusion-weighted sequences. These two can serve the purpose of identifying lesion, especially when you are using a 3 Tesla MRI to identify a site that will be suitable for biopsy purposes in a patient who is at risk for or there is a suspicion for prostate cancer detection. And, few investigators like Stanzioni have shown, and his group has shown, that if you use these limited sequences, just 2 sequences, they can show you very well what is the potential site that should be biopsied. So this is a good example how you tailor your approach based on the clinical need, and the results are admirable as one. So now, if I look at table 3, the table 3 has the standard protocol on the top, and as it shows, there are multiple. It's a parametric protocol. It has multi images. Axial T2, coronal and sagittal T2 is very important to define the anatomy. Then diffusion-weighted images in axial plane to characterize a lesion. It's a part of our criteria, diagnostic criteria, and then is pre and post contrast images. Now, for the biometric abbreviated MRI protocol, on the other hand, it's just 2 sequences. And there is no need for dynamic. We are using FSCT2 weighted axial only and axial diffusion weighted sequence because we don't need to stage. And in an event, let's take an example where they were not suspecting a major prostate cancer, only wanted to biopsy, and you see a big mass. Of course, in those rare circumstances, one can bring back patient and do a dedicated protocol. So that can happen occasionally, but one should be prepared. Overall likelihood of those situations is quite low as we learn to adapt these protocol in our practice. Now I'll move to figure 6, and this figure 6 is from a unfortunate 68-year-old gentleman who had a biopsy-proven prostate cancer. The figure A in this series is axial T2-weighted image that is obtained with parallel imaging. A technique propeller is the name of the technique, which shows approximately 2 centimeter hypointense lesion in the left peripheral zone. And as you can trace the lesion, it is extending to the apex of the prostate gland to midline. One has to be careful once the lesion is in the peripheral zone. You need to look for extension outside the prostate, especially in the apex region. Involvement of the urethra will be important. So we move to images B and C. These are the diffusion-weighted image and the ADC map. And as one can see very obviously, the same corresponding site shows diffusion restriction, and this complies with the prostate diagnostic reporting criteria, which is PIRADS. So this will be classified as PIRADS 5 lesion. So great example, limiting yourself to few sequences and still be able to fulfill the criteria.
Terrific. So now, Dushyant, the final section of the paper addresses some applications in the female pelvis, specifically the issue of ovarian cystic lesions, where MR can be used as an adjunct to ultrasound, and in the evaluation of uterine and cervical neoplasms. We'll show Table 4, which includes an abbreviated protocol that can be used for these indications. And then let's take a look at Figure 8, which is, I think, an example of cervical carcinoma as depicted on MR.
So Jeff, pelvic MR is another area where, MR is such a great tool for both for problem solving, but also facilitating care for staging purposes. And most studies have shown that MR is pretty accurate for these two indications. And what we see that when we suspect a ovarian cystic lesion, our expectations are very different. We are trying to see if this lesion is suspicion. Cystic lesion, you are looking for some solid component which triggers a higher risk lesion, whereas in a known cancer patient, we are not looking for a cancer, but we are staging. So for staging exams, of course, we need a resolution and multi-planar imaging to facilitate the staging question for our referring physician. So the table which shows here is the kind of sequences which will be good enough to give these type of diagnosis. For example, for ovarian cyst surveillance, where we are evaluating few things, axial non-enhanced T1 weighted image, a 3D fast-span echo T2 weighted image, and axial diffusion weighted image can fulfill the criteria that for diagnosis of a cyst into a potentially malignant versus benign. When we look at the table which outlines a protocol for cervical or uterine cancer staging, there is more emphasis on a FSC T2 weighted images. And now these images can be acquired in a 3D with a 3D acquisition, and one can process them into other planes like axial and coronal, or typically we would like them to be perpendicular to cervical canal because that minimizes any potential misdiagnosis for staging when it's aligned to the cervical canal. Then we also propose a 3D FSC T2 weighted image and an axial diffusion weighted sequence for as a protocol for staging purposes. Now I'm showing you Figure 8, and this is again from an unfortunate 77-year-old woman with a cervical cancer diagnosis. Since the diagnosis is established, MR is being performed to stage whether there is parametrial extension or lymph node metastasis. So we have a sagittal FSC T2 weighted MR image which shows a obvious mass as the arrow points to the cervical region. Then on the axial oblique T2 weighted MR image shows parametrial invasion now, so this will upstage the patient to stage 2B, and if it goes further out, it will be more stage 3. And then there is an axial oblique diffusion weighted image which shows a left pelvic lymph node. Again, the arrow points to that finding, which will be suspicious for metastasis. So this is a great example of using limited sequences and fulfilling the criteria for local staging as well as for lymph node detection and characterization.
Terrific. Well, Dr. Sahani, I want to thank you so much for taking the time today to discuss your paper, which is on abbreviated MR protocols for the abdomen, which appears in the current May 2019 issue of Radiographics. Dushyant, thanks so much for your time today.
Jeff, it was my pleasure to speak to you, and I wish the listeners as well as the Radiographics team good luck.
Thanks so much.